So thank you to Sid and the BC Conference for hosting this event. I really appreciate it. It's an honor to be here, honestly. And I appreciate all of you coming here and demonstrating your interest in your cardiac health, because your cardiac health should be one of the most important health issues in your mind. Cardiac death is one of the leading causes of death in our society, continues to be a major threat to our health. And as you'll see, if you can focus on controlling your cardiac risk factors, promoting your cardiac health, you'll be taking care of many other areas of health and minimizing your chances of developing other health conditions and diseases that can be devastating. So it's a good place to focus our attention. I hope the presentation we make today is very clear. One of my motivations for developing talks like this is for my patient education, for the people I see every day in the office who need more information and who we simply don't have the time and the resources in an office setting and one-on-one to give this information to. And you think if everyone just had it and we had that as a starting point, how much further we could go and how much progress we could make. So we're gearing to our patient population, which are people from diverse backgrounds, wide ranges of education and experience and prior knowledge and every habit in the book you can think of, both good and bad. And we try to take everyone where they're at and move them in the direction of health. So that's our target. I don't have dedicated time for questions. If you have a pressing question, please just raise your hand. It'd be great if or shout out. It'd be great if this was interactive and we can entertain on the fly. Chances are what you ask is going to have an answer coming up, but feel free to ask questions, please. So just to be aware, I do speak for a couple of companies of medical devices for cardiology and cardiac electrophysiology. I'm going to feature some of those products today and point out their usefulness. I don't think it's going to be a conflict of interest, but be aware. Secondly, the presentation here is for general information, broad information. This isn't specifically medical advice that I can say immediately applied to yourself. Us having this talk doesn't establish a doctor-patient relationship. If you have a medical problem, you should talk to your doctor. He knows you best and understands you most completely and can give you the best advice for you. That being said, I think the information we have here will be extremely useful. Food for thought. It'll improve your conversation with your doctor, help you get more out of your health care, and I hope you find it very interesting. So we'll start out with some amazing facts about the heart. And the heart is just a fascinating organ. When you choose your area of specialty, you try to choose something that you're most interested in, because you need to be really interested if you're going to, work with that thing all your life and be good at it and pursue your knowledge of it. So this is an exceedingly important organ. It is by far the most important muscle in your body, and it does deserve our very careful attention. So just some amazing facts. The heart is about the size of your fist, really, but you can think of it too as being the size of your clasped hands. And that's sort of anatomic because it's right and left heart pumps that are wrapped around each other in a very close association that makes your heart. So it's a nice representation, and your hand should give you about a sense of the size of what your heart is. So not super big, but not to be discredited. Your heart is first and foremost a giant pump. And with a range of normal heartbeats, your heart will contract 86,000 to 144,000 times per day. If you sat at a heart rate of 70 all day, all night, your heart would beat exactly 100,000 times in 24 hours. It will move 2,000 gallons of blood per day through 60,000 miles of blood vessels. So it's this phenomenal fluid system that is existing in our body and working hard, every day, every moment, whether we're aware of it or not. A heart valve is about the size of a $50. The beating sound of your heart, and I think we've all heard hearts beat either by listening to someone's chest or if you've had the opportunity with a stethoscope, and what you're really hearing is the sound of the valves closing. So when you hear the lubbed up, those are the valves snapping shut as they do. The tethering mechanisms that hold them from leaking are snapping tight and contracting, and then the column of blood that's rushed into those valves and then comes to a stop sends a reverberation throughout your system, throughout your body, and that all culminates in the sound that you hear as heart sounds. But really your first approximation is that the sound you hear is the sound of your valves closing. Before the stethoscope, doctors did press their ears against the chest to diagnose cardiac problems. Interestingly, the heart of a blue whale is about 1,500 pounds. And an embryo heart will be beating at 4 weeks of gestation. So there'll be an intact circulatory system and a beating heart at 4 weeks. It really is just very amazing. Heart disease is the #1 killer in North America of both men and women, and that exceeds breast cancer for females and prostate cancer for men. Heart disease, we found it in 3,000-year-old mummies, and in the picture here you can see a mummy that is about to be passed through a CT scanner looking for health conditions in that mummy. And what we've demonstrated here is a strong coronary calcification or plaque in the main artery to the heart of that mummy that very well could have been the cause of death. So this is not a new disease. It's been plaguing humankind for quite some time. Advanced coronary disease can occur by your early 30s. And statistically, that's going to be true in males 20% of the time and females about 8% of the time. So we almost have to assume already we have significant atherosclerosis, and the question is not if it exists, but what you're going to do to halt that or slow its progression. Depression increases heart attacks. That's particularly true in women. Excessive sitting is linked to heart disease. So while you're sitting in seminars and conferences all day this week, make sure you get up in the breaks and get out and strut and exercise and break that cycle, because sitting here all day is not good for your health. Heart attacks peak on Christmas Day. The next is November 26th and then New Year. So the holidays are very stressful times, and you'll see that if you're working in the emergency rooms on those days. They're packed, and for good reason. So we can say heart disease is the greatest threat to your health statistically, and it is something that we have to be on top of and very mindful as we take actions and steps to protect and promote our health at every stage. Regular exercise is the single most important key to heart health. You have to exercise. Happiness and emotional vitality will lower your risk of heart disease. More education lowers your risk of heart disease, interestingly. And you control heart health, keep the main thing in life, through diet, exercise, and managing your stress. So bad stress, negative stress is very damaging to you. Eating properly and exercising is absolutely essential. So focus on the big picture first and make sure you're addressing each of those components. Amazing facts about the heart. The first study to show the benefit of a vegetarian diet, in fact, appeared in the Bible, 600 BC, where Daniel's very confident. He says, if we can just have vegetables and water to drink, in 10 days, you're going to see we're healthier just by looking at us. And modern physicians have taken that to heart and can promise returns in that same period of 10 days. So here's a doctor from the New York area who says, give me 10 days to change your life. And you should say that's a very realistic time frame, and we've known that actually since about 600 BC. So nothing new, but it works, and you can take action in these times and improve yourself on these orders. Celebrities who have had open heart surgery. If you don't know anyone who's had open heart surgery, now you know of people who have had open heart surgery. There's 4 New Yorkers that I can see instantly on this slide, 2 of whom had their procedures at the Columbia Medical Center. And let's just be aware that even in people who are living high, should be living well, should be very healthy, heart disease is present and at times does involve and require things as drastic as cardiac surgery. So let's focus in on heart disease. And let's think about our hearts the way a doctor or a cardiologist would think about your heart. There's sort of, what are the origins of heart disease in this very complex organ? Well, we can think that the heart really has 4 components. It is first of all, a muscle, and most importantly, it's a muscle. And you can have things that go wrong with the muscle itself. So that's called a myopathy, a cardiac myopathy. Myo is muscle, pathy is pathology. So you can have problems in the muscle. So that may be the source of your woes. And the heart has a system of valves that helps the blood move through the heart, and you can have problems that are mainly arising from the valves. So maybe your heart condition is valve related. The heart is fed by a system of arteries like every other organ in your blood. The heart pumps the blood to fill the arteries, which in turn nourish it and give it its ability to continue functioning. And you can have problems in those arteries. And that's, of course, the most common cause of heart disease in North America is atherosclerosis, or fatty buildup in the arteries to the heart that can block those arteries, cause heart attacks. So we think, is there a problem with the arteries? There's other things that can go wrong with them too. And then finally we realize that this pump is synchronized and coordinated, and it functions because of an electrical system. It's a mechanical pump that's electrically activated. Was the opening sentence of my PhD thesis, and I still think it's the most profound. So your electrical impulse starts very high in the top chambers of your heart. It propagates across those top chambers, causes those chambers to contract. The blood then goes down to these main pumping chambers of your heart, across the valves, while that electrical impulse is also crossing to those chambers. By the time the electrical impulse arrives, they should be filled with blood. They activate the muscle, and shabam, your heart contracts, and the blood goes to your lungs, to your body, and you get to live another heartbeat. So all of these things are sources of health and sources of dysfunction, and we need to consider them when we think about a healthy heart. So I can say, you know, a blocked artery has caused a region of the muscle to die. Because that region of the muscle died, that region is not contracting very well, and that's distorted the valve apparatus, and now this person has a valve problem as well. The source is the blocked artery. Our most pressing problem now is the dead segment of muscle and the consequence that that has had on the valve. So we start to see how these things work together to account for a presentation in any one person. Or we can say someone has a muscle problem, so the muscle has dilated. By dilating, it stretched the electrical system, and by stretching the electrical system, the signal to the muscle conducts very slowly, and because it conducts slowly now, the heart can't synchronize its contraction, so it's beating very desynchronously now because there was a muscle problem that it could deal with, but that stretched the electrical system. So now it's become mainly an electrical problem that we have to address to fix the problem with the muscle. So we play with these things and try to explain each patient kind of by considering each of these 4 areas. And those are things in your heart that, that you can be aware of. So coronary artery disease, not a difficult concept. We have arteries. Arteries are tubes that conduct blood. And over time, atherosclerotic plaque, which we've all heard of, can build up in the walls of those arteries. And as that plaque continues to build up, the conduit for the blood flow gets more and more narrow, and it can eventually completely block off. And if it completely blocks off, well, then all the muscle that's fed by that artery will suddenly not have oxygen, and it'll die. And that is a heart attack and results in an infarct or scar that replaces that what once used to be viable muscle. So kind of as that artery gets more and more narrow, and as the blood supply limits, you'll start to feel cardiac chest pain. You'll start to feel crushing, squeezing, pressure-like sensations in your chest during exertion when the blood demand to your heart increases, but the vessel's not there to provide that blood. That's classic cardiac chest pain from that sort of chronic, stable progression of coronary artery disease. So that's sort of the first concept to have in mind when you think about coronary disease. But it isn't stable, slowly progressing coronary disease that is in fact responsible for most of our problems. And we'll explain that a little bit more later. The question now becomes, do you have coronary artery disease? Is there atherosclerosis in the arteries to your heart? for you and for me. I don't know if I have it. You probably don't know if you have it. So we think about risk factors. What are the risk factors that increase the likelihood that you have blockages in your arteries? And we have conventional risk factors. Age above 45 for men, age above 55 years in women. If you have a strong family history of heart disease, certain races are more predisposed to coronary disease. If you have low HDL cholesterol, which is your bad cholesterol, or your good cholesterol, sorry, your heart is left unprotected. And, we can't change how old we are. That's what we call a fixed risk factor. What we'd like to identify is the modifiable risk factors. What are the risk factors that we can improve to decrease our chance of ever having heart disease? We can lower and change our cholesterol levels. We can control our blood pressure. We can stop smoking if we have a problem with smoking. We can make dietary changes to control diabetes. We can be compliant with our meds and control our blood sugar levels. We can lose weight. We can increase our physical activity. And hopefully we can relieve ourselves of mental stress and depression. All of these things with the goal of improving your heart health and decreasing your chance of having atherosclerosis, that slow buildup of plaque in your arteries, which can transition to being an atherothrombosis, when that plaque then ruptures and a blood clot quickly forms on the region of rupture, and suddenly an artery that's only 50% blocked by plaque is 100% blocked by thrombus, like that. And now your artery's totally occluded and you're in the setting of acute heart attack in somebody who never knew they had coronary disease. That's a very real scenario. So symptoms of coronary disease, things to take very seriously. We talked about the classic symptoms being that heavy, squeezing, crushing chest sensation that lasts. It's hard to relieve, maybe by rest or with nitroglycerin medication if you happen to have it. And classically, that pain will radiate into your left arm, your shoulder, maybe up to the left side of your neck. That is classic. But your body maybe didn't read the textbook, and we have to be very aware of other sensations that can mimic coronary disease or be caused by coronary disease. Particularly in females who tend to have atypical presentations. They don't follow the classic pattern that we've described, and for whatever complaint they may have, we have to be very suspicious that it may in fact have a cardiac cause. You can, in general, be relatively reassured that your chest discomfort is not coming from your heart. If it is pleuritic in nature, so it changes with your breathing, if it has a sharp or pricking or knife-like sensation, if when you press on your chest it hurts more, it's probably not your heart, it's probably in your chest wall. So you have something else going on, and that should be reassuring, and that also tends not to last as long and be more random in our offset. In its onset. So the clinical history and the story you tell us when you come in complaining of chest discomfort is very important in shaping your doctor's pre-test probability, or the probability that you have coronary disease and there is really something taking place in you right now. We make a decision. Are your symptoms or your chance of having coronary disease worthy of an investigation? Do we have to look further in you? And there we talk about stress testing. We can have you walk on a treadmill, look for electrical changes. Perfusion imaging, inject your heart with dye, watch the blood perfuse your heart, see if there's areas with flow limitation. We can do it with ultrasound of your heart, watch if your heart's beating uniformly and strongly in all of its segments. Or angiography, inject dye into the arteries of your heart and just look for blockages. See if they're there with the chance of reversing those. Treatment, should we find something, includes lifestyle changes and good medications always. It's possible to stent open blocked arteries, so we balloon them open and we deploy chicken wire to hold them open. If your disease is too complex or you're not amenable to stenting, you can go to bypass surgery, and those surgeons will go in and they'll put conduits that surround your areas of blockage to give you blood flow to your heart. You may need a pacemaker, you may need an implantable defibrillator because of your cardiac disease. If you are going into heart failure and these therapies aren't enough for you, you may go on to have a ventricular assist device, which is a mechanical device that's going to help your heart pump. And failing that, or in case you weren't a candidate, you could progress to a heart transplant. Someone who's known to us who had both the ventricular assist device and the heart transplant is Dick Cheney, senior member of the Republican Party. So he is now post-heart transplant, having transitioned through that VAD therapy. And if you're in the United States, that was kind of big in the news while he was going through that. Unfortunately, he's doing very well. So that's kind of a common or a well-known person who has undergone exactly all of these things and still done quite well, been able to continue in his career, et cetera, and continue to be fairly high functioning. So if you go to stress test, let's say we decide that you deserve to be stressed, we're going to assess your heart's ability to respond to stress. Exercise is best, either with a treadmill or a bicycle. So here is a gentleman who's hooked up with his ECG electrodes. We're taking his blood pressure, and he's on the treadmill ready to go. And that treadmill is going to go slowly faster and steeper as he exercises harder and harder. And we're going to try to get him to exercise absolutely as hard as he can, and then look for evidence of coronary disease with the ECG or with perfusion imaging or with an ultrasound to look for contraction abnormalities in his heart as they develop. So on an ECG, what you might show in the presence of coronary disease is here's your heart signal, and if these segments start to depress and flatten like you're seeing here, that's an evidence that there is a significant blockage that needs to be investigated. If we do nuclear perfusion imaging, here you see your heart in cross-section, and the nice glow is the tracer lighting up all the regions of your heart under rest. Shows there's good blood flow to all of those segments. In the setting of stress, you can see that there's an area now of dropout, not receiving blood anymore, probably because the artery supplying that segment of the muscle isn't perfusing well. And that's a signal that the vessel supplying there has significant disease and maybe deserves our revascularization, so we can go in and try and open up that blood vessel and restore blood supply. So these are the things that I know several of you in this audience who I've talked to already have undergone, and maybe in your future, should you develop symptoms of coronary artery disease. Here's the same scenario now where we exercise you, and when your heart's beating vigorously, we'll quickly take an ultrasound of your heart and look for contraction abnormalities that have developed in response to you exercising, and we'll take that as evidence for blocked arteries, and then make decisions whether we need to go chasing those blocked arteries and start opening them. So all of these things are in our armamentarium. Should we decide that there's a good chance you have a blocked artery and you go to the cath lab, here we're doing angiography, lighting up the blood vessels to your heart with dye and looking for blockages. And here you can see a little area of narrowing which has developed in this individual. Here you can see this blood vessel just abruptly stops. And once it's been opened on this side, you'll see the blood vessel clearly lights up the entire blood vessel and beyond, restoring blood flow to that artery. And that's done using a stent device where we pass this device, it's kind of like coiled up chicken wire through that area of obstruction, deploy that chicken wire, it's called a stent, against the wall of the artery, plaster all the plaque up against the artery, open it up, restore blood flow to the heart, can give you a new chance at revascularization and having normal heart function. Nevertheless, we hope that this is not necessary for you. It isn't necessarily reversing your health problems, reversing your atherosclerosis. It's just taking care of that one discrete problem that's an immediate threat to your health right now. So if you have lots of blockages, like this angiogram shows, here's a blockage here, here's a blockage here, one here on the right side, you may require bypass surgery, where now we have cardiac surgeons opening your chest and using blood vessels to connect other arteries from your body to the arteries to your heart, such that blood flow can bypass those regions of blockages. So we use arteries, and we'll also use veins that are available in your legs, and which can go from your aorta to sites in those arteries around the blockages. So we're restoring the blood flow to your heart, allowing that heart muscle to recover. When we're done, you get closed up, and like here's someone with a large sternotomy scar who's had open heart surgery and bypass surgery. So signs of advanced coronary disease, consequences of advanced coronary disease, which are wonderful, they're life-saving, we're thankful we have them. We'd like you to stay healthy such that you don't need these things soon or in the distant future. So again, going back to that pathologic process where here we have a nice normal artery, and over time, starting in your teens and 20s, atherosclerotic plaque begins to build up in the lining to your heart, in the lining to your blood vessels. Your blood vessels will try to disguise that by putting smooth muscle cells that typically line vessels over top of them, but nevertheless, there'll be this pool of lipid, mainly cholesterol particles, within the walls of the vessel that leave those vessels compromised. As that plaque grows, there is an increased risk of that plaque eventually rupturing. So here you see it's soft. This isn't a very well-formed structure, and in a time of stress, that plaque ruptures. Suddenly all that fat is exposed to your blood. Your blood says, oh, you're bleeding, better clot. So a blood clot forms on that area of rupture, and that blood clot can then rapidly expand and completely block an artery which was only partially blocked just a few minutes ago, resulting in the acute presentation of chest pain. This guy suddenly develops squeezing chest tightness, signaling that he does have a heart attack, he's developing a heart attack, and he needs medical attention immediately. So where you or I are along this process, most of us don't know, and we probably won't know, including myself, unless we undergo the sorts of testing that we've talked about. What we can focus on, since we probably won't get those tests or ever warrant them, we can focus on controlling those risk factors to prevent the development of coronary disease, which could be taking place right now in the vessels of our heart and also the vessels throughout our body. You know, you can have vascular disease by very similar mechanisms throughout your body, including your brain, where similar events like this result in strokes rather than heart attack. And we want to minimize our chances of having any of those events. So, for heart attack, know the signs. We should all know this. You can recognize it in yourself, or you can recognize it in someone else if it's happening to them, and help them get assistance. We know that a heart attack can occur at any time, and it's not always sudden and intense. So we maintain an index of suspicion. We know that 50% of sudden cardiac deaths actually occur outside a hospital, suggesting that people aren't acting on early warning signs. So if the warning signs are there, you know, take action now, don't sit on it. Recognizing a heart attack warning sign can save a life. Even minutes can make a difference. Many heart attacks start slowly with only mild symptoms or discomfort and escalate or just smolder along. So if it's there and it's not going away and you have concern, be checked out. If you're experiencing these things, the best advice is to call 911 or go or have someone take you directly to the emergency room, where we can start doing blood tests and ECGs and monitor you and really decide if these things are happening and if we need to take action quickly. So his and hers heart attack symptoms. For women, we said the presentation's vague, and it is vague, so we maintain a higher level of suspicion in a female complaining of these things. Unusual fatigue or sleep disturbances, shortness of breath, indigestion, anxiety. It's always in the back of your mind, is this a heart attack that's developing? For men, shortness of breath, weakness, unusual fatigue, cold, sweaty, dizzy. For both arm, neck, back, jaw pain, feeling faint, nausea, abdominal discomfort, shortness of breath, sudden perspiration, you're sweating for no reason. That's got to be on the back of your mind as to what may be taking place. And time is muscle. Time is muscle, as we say. If that heart attack is evolving, it needs to be evaluated now, because if we can restore blood vessel now, we can save heart muscle from dying, which will help your heart maintain its function, help you live longer. Of the people who die of heart attacks each year, nearly half die within an hour of the first symptoms, and that's before they reach hospital. The less time that passes between the start of heart attack symptoms and the restoration of blood flow, the less damage your heart is likely to sustain. If you go to the ER by ambulance, the emergency responders can take action on you and offer treatment for you before you get to hospital. So if it's really happening and you're really concerned, call the ambulance rather than drive yourself or have someone drive you. Hospitals now try to maintain what we call a 90-minute door-to-balloon time, meaning if you walk in complaining of symptoms that may represent a heart attack, our standard is that within 90 minutes, if it is necessary, we need to have your artery opened in the cath lab. 90 minutes. So that means we get you in, quickly take your history, do an ECG, look for the pathologic changes, do the blood test, see that the troponins or blood or proteins from your heart are rising in your blood, and if the presentation is right, the cath lab and the physician in the cath lab need to be available to have you on the procedure table with a catheter in your heart, stenting open your artery within a 90-minute interval of you walking in the door in the first place. That's a national standard, and we're getting better and better at maintaining this standard, and the actual door-to-balloon time has dropped to 60 minutes in many centers, which is really good, you know, and it's a nice effort on the part of the hospital to coordinate. What has to happen for that 60-minute door-to-balloon time to benefit you is you have to get there soon enough, you know? So don't be sitting on these things if you really suspect that it's taking place, or you suspect that it's taking place in somebody near you. So that said, and we'll talk about health changes we can make to minimize our risk factors. That's coming up. And I know this is a health seminar, so what can we do that is coming up? It's just important now that we understand the disease process. So bear with me a little bit longer. We have this problem of sudden cardiac death, which can be an occult presentation of coronary disease. What do we mean by that? Well, what is sudden death? Sudden death, by definition, occurs unexpectedly. It's sudden, it's without warning, death occurs within minutes, and the whole event is kind of cardiac in nature. There's 350,000 cases of this per year in the United States, you know, and that numbers represent, you know, it would reciprocate in Canada, just scale it to the population, and that's about 40 cases per hour. So you can think if we spend an hour and a half together here today, statistically 60 people in that time had a sudden cardiac death event in the United States, and 20% of those individuals will survive. So this is where the quick response, the CPR, the emergent medical treatment, able to act quickly enough, can save a certain number of people who are having this, but you know, an 80% mortality rate, and that for 300,000 cases per year, really quite staggering. And the sudden cardiac death sudden cardiac death as a cause of death exceeds and about equals that due to stroke, lung cancer, breast cancer, HIV/AIDS, all of those things combine to match the burden of disease and death from the cardiac cause. So let's be aware sort of the magnitude of this, and we can place it in relationship to other conditions. So, who are the people who are going to have this? You know, who's that 300,000 who will experience sudden cardiac death unexpectedly this year? This is a very profound graph, if you can bear with me. Here is the absolute number of people. So see up to 300,000 people of sudden cardiac death. And in which population are the majority of those events? It's the general population, just the general population, or individuals who are high risk for having coronary disease. You're high risk, but you've never had the clinical event. We don't know for sure you've had blockages because we've never worked you up. That group, which is kind of reflective of the group sitting here, will account for the majority of cases per year. Their risk is exceedingly low, so the incidence is very small from a percentage point of view, but in fact, those will be the majority. As you develop coronary disease, you have events, as your heart starts to fail in response to your blocked arteries, once you've had an event and survived it, your percent chance of having a recurring event really starts to climb, but you will in fact account for fewer of those events overall. You join a high-risk population that's more likely to succumb to sudden cardiac death, but in point of fact, that's a minority of people who actually experience it at a population level. So let's just be aware that that subtle coronary disease or coronary disease that you don't even know you had puts you at risk for being in this group of people who will suddenly experience a cardiac arrest. Sobering numbers. So what happens? What are the causes of sudden cardiac death? This is typically an arrhythmia death. You'd think the muscle just died so the heart doesn't beat anymore. It's partly due to that, but in that process what in fact happens is you develop very fast heart rates in the bottom main pumping chambers of your heart, where your heart is suddenly beating far too fast to pump blood effectively to your body, and that is in fact the cause of death, is that very rapid heartbeat that develops in patients who are having that acute heart attack, for example. 10 to 20% are due to just pump failure. Your heart attack is so massive that the heart can't contract, so that's obviously a cause. And we always have to remember that sometimes the heart is just going too slow in that setting, and that's the reason. But for the vast majority, and common things being common, it's these very fast rhythms, and as a result of that, this is what you see, the defibrillator pads. And we quickly recognize these fast rhythms and we deliver shocks to the heart, and by delivering shocks to the heart, we attempt to restore those abnormal rhythms back to normal. So here's kind of a fun picture of us demonstrating this in our electrophysiology lab. We always have this equipment in the hospital. This is the biggest defibrillator on the market today. And here our student has the pads placed on me. And let's be aware that those shocks are very powerful. And if you were not sedated or unconscious because of your arrhythmia, you would experience a tremendous amount of pain from that shock, and your body, really does contract and sort of jump off the table in response to it. It's a necessary thing. We have to deliver enough energy to make sure we get you out of that rhythm. So let's be aware that this is what this looks like. Arrhythmias causing sudden death. Again, the very fast rhythms, all of these, with slow heart rates or bradycardia, just accounting for a small minority of these. And again, we ask, why do sudden cardiac death victims have a ventricular tachycardia or fibrillation, which are these very fast heart rhythms? Why does that very fast heart rhythm start in these people and actually be the thing that causes their immediate demise? So we say coronary artery disease is over 80% the cause in Western countries. So it's the coronary disease that's causing the fast heart rhythm, which actually is what drops you and is the most immediate thing that is responsible for your demise. And we have to be aware that this can be our first evidence of coronary disease in 60% of women and 50% of men. So you don't know you have it, you'll be like a large number of people, where you dropping dead will be the first time we go looking for it, and in fact find that you have significant coronary disease. Again, here's the progression. You have this stable plaque in your artery. You have blood clots forming on that plaque. When it becomes torn or disrupted, this can result in a total occlusion. The total occlusion leads to acute heart attack. That heart attack and dying muscle causes electrical stability, where your heart goes from a very normal rhythm to suddenly, instantaneously, this very fast heart rhythm, which on the order of several minutes, if it's not interrupted, you see those signals becoming smaller and smaller, more disorganized and more disorganized, until you are truly flatlining and your heart is not beating or pumping any longer. Should you survive your heart attack, you're now left with a region of scar in your heart, which can also be electrically destabilizing. And your risk of having this event, even though you're walking around feeling fine, is higher because of that presence of that scar. In people who we think are high enough risk, we'll offer them an implantable defibrillator, a device that could recognize those fast rhythms and quickly shock the heart back to normal. People walk around with implantable defibrillators. If you don't qualify for the defibrillator because your risk isn't scored high enough, just be aware that your risk is still elevated from a statistical point of view. So what do we do for people who have had a sudden cardiac death event? So say this had occurred to you, you had dropped, we'd shocked your heart back to normal, brought you to hospital, now, what's next? We treat known coronary disease, so we try to revascularize, open blocked arteries, go around blocked arteries, get you on appropriate medical therapy. We'll start to modify your risk factors for CAD. We want to control your blood pressure, your diabetes, smoking, stress, inflammation, improve your diet and exercise. You get medications to promote the recovery of your heart. Beta blockers, ACE inhibitors, statin medications. I know many of us are on these things for a variety of reasons, including this. We promote electrical quiescence so those abnormal heart rhythms don't start. Again, beta blocker medications to blunt the stress response to our heart. And then in people who are still high risk, protection from breakthrough arrhythmia with an implantable defibrillator, or sometimes a wearable defibrillator, which is like a piece of clothing. All of these things to minimize your chance of having this again and to rescue you should it happen despite our best efforts to prevent this from happening again. So again, the implantable defibrillator, who in our society and by our medical guidelines deserves one of those. If you've had a sudden cardiac arrest, you get one by definition. If you have heart disease that's severe enough that your pump function of your heart has deteriorated sufficiently, we'll give you one anyway, just because your risk of having a recurrent event is high enough, or having a first event, is high enough statistically. So that portion of our population we choose to protect, again, appreciate that that does not include the vast majority of people who will actually suffer a cardiac death event this year. But those who are truly higher risk, even though that's a minority of that absolute number, we will offer protection to. So if the iceberg represents everybody who will have sudden cardiac death, 350,000 people a year represented by the iceberg, everybody under the water doesn't qualify for a defibrillator. So we wouldn't have recognized their risk enough to offer them protection in the first place. Everybody above the water, we would say are within guidelines to receive an implantable defibrillator, and those who actually get the device and implant it are what I've circled in pink here, and that's less than 20%. So less than 20% of those who meet guideline criteria for devices this protection will ever actually receive one, which is a cause for pause about how we're mitigating individual risk and how proactive you may need to be in advocating for yourself or for your family members should you ever find yourself in this situation. So I've talked about a couple of things, the pump function of your heart being low. What is the pump function of your heart? Let's just touch on this. I know it's a question that my patients ask me repeatedly, and I know you're not necessarily a cardiac population, but I think it's worth touching on. This is the left ventricle. That's the main pumping chamber of your heart. So it fills with blood when it's relaxed, and then it contracts to pump that blood to your body. And the amount that chamber empties when it contracts is what's called your ejection fraction. A normal ejection fraction is 60%. So it doesn't expel all your blood. It ejects about 60% of the volume that it contained. So we say 60% is normal. That's the first thing to reassure people when you tell them that their ejection fraction is 30%. It's only half normal. Yours is half normal. It's not 30% relative to 100. But when it is 35% and below, we start to understand that the arrhythmia risk is high enough because of that low pump function that we would offer you permanent defibrillator protection and encourage you to accept that therapy. So that's the pump function. We measure it on echo. It's the amount of volume that chamber actually contracts and ejects with each beat of the heart. For those individuals who may need a defibrillator, these are our options. Historically, it was always what we call the transvenous ICD. So this device sits under your skin here, and through your vein, through your blood vessel, we pass this wire into your heart, screw it into the wall of your ventricle, your right ventricle, and there the device sits with this shocking coil. It's a computer, it's monitoring your heart rhythm, and should that very dangerous fast rhythm ever develop, it's gonna try to forcefully pace you out of that rhythm by bursting pacing into your heart, and failing that, if the rhythm persists, it will charge up, and between the shock coil and the device, there'll be a large volt of energy, and it will completely reset your myocardium and hopefully be enough to abort that rhythm, which would otherwise be life-threatening to you. So for decades, this was all we had, and they're very good. Recently, we have this other kind of defibrillator, which none of it goes through your blood vessels and into your heart. The whole thing sits under your skin. It sits here under your skin and in front of your sternum under your skin, and that defibrillator system is able to sandwich the muscle of your heart enough that it can detect the rhythm, and should you have it, it can deliver the same shock, the same life-saving therapy without exposing the individual to hardware that actually goes through blood vessels and into hearts. And that's something that's very important to us for our young patients who are doing very well, need a defibrillator for that protection. We're very reluctant to pass hardware into their heart, into their blood vessels, because no one can guarantee that hardware is going to work for the next 30, 40, 50, 60 years of their lives. And complications down the road are things that we'd like to avoid for people. So a remarkable technology, 3 or 4 years old, which really does give us some exciting options. Here's what those two would look like on an x-ray. Both of these are my implants, so I'll take the credit or the blame for anything that doesn't look like it was well done. Here's the defibrillator, nicely over your chest wall, so it's not interacting with your arm. You see the wires passing, one into the top chamber of your heart, the other into the bottom chamber of your heart. Here's that defibrillator coil, which can charge up and deliver a shock passing right through your heart muscle here. This structure here is your heart, of course, and reset that rhythm to normal. And here is the subcutaneous defibrillator under your skin on your side, with that shock being in front of your sternum, just under your skin, and that whole system being able to sandwich your heart well enough, get all the meat in the sandwich, so that when electrical shock does pass through the body, it will include the heart and reset the rhythm to normal. We're one of the highest implanters this year in Washington State of these devices. And it's our lab, and it's interesting. I just think we have that. It's bizarre. We just have that large population of young people who really do deserve defibrillator protection. So here's a story: 59-year-old male postal carrier worker, very fit fellow. He suffered sudden cardiac death in his bed at night. He had applied multiple testosterone patches to his body in an attempt to, improve his performance. We didn't think that was enough to completely reverse his risk. Take off the patches, please. And he received an implantable defibrillator. The actual device looks like this. Under your skin, it could very much look like this after the implant. For people who have larger chests or bigger, they hide the devices better. This is a very fine implant, and kind of what it looks like, and kind of the system that you have. So again, wonderful technology that can save lives, do tremendous things. I hope for everyone here that you never qualify for one, and that we never have to offer you this level of protection, because you've been blessed with good health and you've cared for your health long enough and well enough that any cardiac disease has never progressed to where that this is necessary. But let's be aware that this is where all this is headed. The coronary disease, the bad lifestyle, the heart attack, the second heart attack, this is where we're going. And this is what we'd like to avoid. So here's our implant procedure in our electrophysiology lab. This is the little incision in the skin to actually put the device. We have technical staff from the companies who are helping us program these devices, get them just right for the patient, register everything, make sure all the characteristics are perfect before we close up. And it's something that we pride ourselves on tremendously, is giving good implants and doing a good job of this. But again, wishing that our patients were well enough that they didn't need this level of protection against sudden cardiac death. Here's that subcutaneous defibrillator I told you about, fits under your skin, sandwiches, provides you with the same level of protection against dangerous rhythms. Here's on post-operative day 1, a gentleman who received one. Here's that incision on your side and the two in front of your sternum where that lead is placed. 56-year-old man, mild coronary disease, diabetes type 2, depressed ejection fraction, 30 to 35%, despite of the fact that we've had him on good medical therapy for a long period of time. And he's somebody that we had implanted back in December of 2013. On this slide, you can see that the device is significantly back enough and the shock electrode is sufficiently in front enough that should a shock need to be passed between those two pieces of hardware, it would very well pass through the heart, which is this structure here, and capture all of that tissue and be able to reset the rhythm to normal. So just another example in somebody who is thinner. This is a 52-year-old man. He's had PCI, or a stent placed to his left anterior descending coronary artery. Despite of these interventions, his pump function has stayed low. And as a result of that low pump function, sustained low pump function, we recognize that his risk is significant, and he qualifies for one of the defibrillators. As a bridge to a defibrillator or to recovery such that you don't need one, we have this technology, very new, and it's something we're using more and more in our practices, and this is a Lifevest. This is a clothing vest that you can wear, which has all the components of a defibrillator that you need and can provide you with that protection while we're waiting for your heart to recover or for the appropriate time to implant you with a permanent device. Looks very much like this. There's a defibrillator electrode in the middle of your back on the vest, also one right over the apex of your heart here. Here's a battery pack that you can recharge every day. And, it actually works extremely well. You can wash the garment and have defibrillator protection for as long as you're wearing this. And here's a media piece we did just last week of one of our patients here, Leroy Gamble, 79-year-old, who came to us with a cardiac arrest. So he was somebody who had a sudden cardiac death event in the field. We didn't know why. He was resuscitated by friends and family, brought to hospital, spent time in the ICU, recovered, ready to leave hospital. We wanted to implant him with the defibrillator. We needed some time to improve his medical therapy before we did that. We gave him a Lifevest. Significant risk of having another event, but still pretty low. We thought that he probably wouldn't, but then within a week, getting up from watching TV to go recharge his phone, walking across the floor, he suddenly passed out, hit the floor, and on the floor, his Lifevest did shock him back to a normal rhythm appropriately, and was life-saving therapy for him. So we featured him and his story in our local newspaper. And, that was very interesting for our cardiology group and something that he was gracious enough and very happy to participate in. Let's go one step further, just so you understand the range of therapies that are available should you develop advanced cardiac disease, which is where all this is headed should things get out of control and not be managed appropriately in time. Heart failure therapy. What is heart failure? These are symptoms of heart failure. People with heart failure can have shortness of breath, they'll find swelling in their feet and legs, chronic lack of energy, difficult sleeping because they can't breathe, confused, impaired memory, they need to pee a lot at night, they're coughing, but it's kind of a frothy cough, and the abdomen may be swollen and tender from fluid accumulation. This is pitting edema, where you press on the individual's leg and this indentation persists for quite a period of time. And that's due to fluid accumulation in those tissues. In this individual, that's a result of heart failure. Somebody who's acutely in heart failure and in hospital for this can sort of look like this, and we understand the pathology. They're confused, they have fatigue, they have an enlarged liver and spleen, a large abdomen, they're not peeing very well, they have a very weak pulse, cool and moist skin because they're not having much of perfusion. Ascites, as the stomach swells with fluid, they're nausea, vomiting, the blood pressure is low, and they're short of breath with crackly, wet lungs. Skin is pale, it's gray, the pupils become dilated. This is somebody who's suffering from acute heart failure, which we understand is, here's a normal heart, now that heart has dilated and reduced its pump function, which is the pathology which is causing our patient to feel this way. So we need to address this state, move this heart towards this heart to improve his condition, and hope that we can do this well enough with medications so we don't have to go on to advanced therapies. And we have the New York Heart Association has classified symptoms. So really, if you're a heart failure patient and with sustained exercise you become symptomatic, you're class 2. If daily life with ordinary activity you feel symptoms, you're class 3. And even with you're at rest, if you're having symptoms, we'll call you class 4. By the time you're having heart failure symptoms of this magnitude, your chance of dying in the year becomes significant. For class 2, it's 10 to 15%. Annual mortality, 20% for patients who are class 3. 50% of those who are class 4 have that mortality risk per year. So we try to recover people out of these classifications and move them to higher classes and hopefully even to class 1 with good medical therapy, with device therapy, because we know that the mortality statistics are significant. So we want to protect our hearts so that we don't develop this, recognize this is still the leading cause of death in North American society, and if we focus our attention on health around cardiac health, that's going to do us a lot of good, and it's going to benefit us in many other ways, improving our odds and our chances and our control of a multitude of other medical conditions, because they're all so closely related. So this becomes a good focal point for just about anyone. So we've talked about the cardiac conduction system. It's an electrical system. That electricity is inscribed or recorded by an electrocardiogram. This is a nice slick electrical signal in a healthy heart. You can see these signals are very brisk. In someone who has developed significant heart disease over time, we see that the electrical signal becomes broad, can become broad. So the electrical activation of the pump is very sluggish. Now, not only do you have a heart that's failed and dilated, it can't coordinate because the electrical signal to contract can't spread across the heart rapidly enough for that heart to coordinate itself. And exactly how I say to my patients, I tell them one side of your heart's getting the signal to start squeezing, and it starts to squeeze way before the other side of your heart even knows to start. And as a result, it's going like this, when it needs to be going like this. And that lack of coordination, or that loss of coordination, is a reason why we're not able to reverse your heart failure just with good medications and lifestyle changes. It's an exciting opportunity because this is a place where device therapy can really be transformational, and you can really feel like you're giving patients their life back. And that is, again, with defibrillator implantation, because the risk is high. Notice in this system, not only do we have that single lead in the bottom chamber, we've now passed the second lead through the venous system out to the other side of the heart. Now I can pace the heart from this side, I can pace the heart from that side, improve the coordination of the contraction, which can be the stimulus that heart needs to pump more effectively and to start recovering. So here we see that device on X-ray, and what you'll see is new is you recognize the defibrillator lead, but here we have this thin pacing lead way out through the venous system around the other side of the heart. And we're able to pace from both sides, narrow that electrical signal, reverse the degree of delay, coordinate the heart, and help that person's heart recover its function, help that person feel better, help them live longer. It's very satisfying. People can feel better even getting off your operating table. It's really quite remarkable, and something that we pride ourselves on. So again, I hope none of you progress to where you need this sort of therapy. I think it's important to be aware that it's available. And again, to draw on Dick Cheney, beyond the defibrillator, beyond the resynchronizing device, what do we have to offer you? A mechanical pump that will replace the function of your heart chamber, and we'll use that as either destination therapy, meaning that's it for you. We're going to leave that on for the rest of your days, and we hope we can do well for you, or as a bridge to heart transplant, where we say, we have to replace the entire heart. And I should mention too, as a bridge to recovery. If this is enough for your heart to recover sufficiently, wonderful. If not, it's either going to be how we keep you alive for the rest of your days, or we are going to eventually transplant you. So here is Dick Cheney at a time when he was wearing his defibrillator, his ventricular assist device, and he's at work and he's functional because of that device. And of course, he did go on to have heart transplant therapy. So we'll be aware that these things exist, and this is the slide we showed yesterday for heart transplant, where you are relying on an unfortunate event happening in someone else's life, such that they become a heart donor, and then if your number is up on the list, because the list of people who need these things is long and the list of donors is short, you can receive that patient's organ and have a new lease on life. Again, something I'm hoping everybody in this room is able to avoid and probably will avoid. Just be aware that this is the end of the line in terms of cardiac therapies that you might be eligible for or that we have to offer people. This is it. So we want to interrupt this pathology way upstream before we ever progress to where we are candidates or in need for this kind of therapy. So let's move on to prevention and wellness, and we're going to be right on time. Preventing coronary disease with the goal of preventing heart attacks and the goal of preventing sudden cardiac death. So we saw that progression of disease. This is the pathology we're trying to stop, where that atherosclerotic, where the lining of the heart becomes damaged by free radicals, toxic exposures, they're like barbed particles that damage the lining. That allows oxidized cholesterol particles to start to build up in the walls of the artery. So it's not just cholesterol that's bad. It's cholesterol that has been damaged. It's damaged cholesterol that is pathologic to your arteries. Damaged by free radicals, toxic exposures, which are products of inflammation. We need to not just reduce our cholesterol, we have to protect our cholesterol so it doesn't become pathologic. Pathologic cholesterol does exist. It continues to build up. The wall of the blood vessel becomes compromised. You're building muscle to disguise this, pretend it's a normal vessel, but we know it's not a normal vessel, and that plaque may at some point rupture, allowing a blood clot to form, which can be that sudden catastrophic event. So again, this is what we are trying to prevent with lifestyle changes. So you ask, well, if it's really the vulnerable plaque rupture that I may be at risk for, how do we prevent that? And we talk about the balance of the autonomic nervous system. You have a resting nervous system and a stress nervous system. This is what you don't have conscious control over. It's just oscillating like this in the background, trying to juggle, keep you kind of at equilibrium. And you want to always be biasing your system towards your resting state, because your resting state is the one that's going to protect your body from the harmful effects of stress and protect your plaques from ever having that rupture event. So if someone's plaque is going to rupture, the sequence of events is kind of a shift in the nervous system towards the stress state. With that, there's a shift in energy substrate, where your heart, which normally likes fat, your heart wants to burn fat for its fuel, it switches to sugar to burn, which will then increase production of lactic acid. The lactic acid on the cells prevents calcium entry, which the heart cells need to contract. So contractile dysfunction in the muscle then develops, and that muscle gets stiff. The stiff muscle surrounding your vulnerable blood vessel has increased pressures and shear stress, which can be that trigger event that'll rip that cap off of your atherosclerotic plaque, resulting in a heart attack. So protecting ourselves from shifting into that stressful state, that shift in our autonomic nervous system to that swing towards the dangerous side is the event that we should recognize as being dangerous, and what we should be adjusting our lifestyle to reduce. So what are our strategies for cardiovascular health? It's lifestyle, social, stress, just for that reason. And your habits, we'll talk about habits, and your exposures. What are you being exposed to that's harmful to you that you need to probably take control of? We talk about improving your diet, and the buzzword is the plant-based whole food diet, meaning you're eating plants and you're eating whole foods, meaning it's the plant just the way it grew out of the earth. The more you're doing that, the healthier your diet is. And I'm going to add to that you want organic food sources. Either you grew it yourself, it's from a local farmer's market, so you knew how it was grown, or you're buying it from the organic section of your grocery store, because that's going to have the greatest nutritional density in that food. Exercise. Without going into an extensive thing on exercise, I'll give you this buzz: low intensity continuous motion. Heart health, your health and longevity is not you exercising ferociously for half an hour a day or on the weekend. It's you having low levels of activity in all your limbs all day. So you're kind of always in motion, or if you're at rest or sitting still, you're interrupting those patterns and you're going into low-level, continuous, whole-body activity frequently. The societies with greatest longevity live that way. The lifestyle pattern that we can best adopt is exactly that strategy. We'll talk about cholesterol. Of course, cholesterol can be a problem. A lot of it is genetic. This is a laboratory measure. And we'll focus on inflammation, which is a product of your lifestyle and a product of your exposures. And we'll use inflammation as a grand unifying theme to focus on to best protect our cardiac health. So we have one word, one target. We'll go after that, and we'll know by pursuing that one thing, we're going to give ourselves the best chance of success. So a little bit on cholesterol, because I know everyone wonders about cholesterol. And cholesterol is a moving field in research and in our dietary guidelines. Guidelines have just shifted dramatically, breaking decades of precedent in recommendations regarding cholesterol. So let's be aware of what those are and why they happen. LDL cholesterol is your bad cholesterol, so we think lower is better. HDL, we always know, is your good cholesterol, so higher is better. Triglycerides are a form of fat storage in your body, and we think lower is better. So we want high HDL, low LDL, and low triglycerides are historically a good lipid profile. And we recommend that your cholesterol levels be lower as your other risk factors increase. And if your other risk factors are excellent, we'll allow you to have higher cholesterol levels and be less aggressive about instituting cholesterol therapy. That's sort of always been the large paradigm. If you have diabetes, this becomes a significant risk factor for heart disease. So in you, the cholesterol guidelines become much tighter. In fact, if you have coronary disease, an LDL of less than 70 milligrams per deciliter becomes your target. And that's aggressive. I apologize, it's in US units, but that becomes very tight guidelines because the importance of LDL and its presence in atherosclerotic plaque has been thought to be so important that the guidelines are saying, get that down. And we've proven that that is life-saving. I'll make the point again, it's not your cholesterol, it's your oxidized cholesterol. It's the cholesterol molecules that have been damaged and are still in your circulation that are pathologic. So we're gonna work on protecting our cholesterol as well by focusing on reducing inflammation, because inflammatory processes are the way that cholesterol molecules get damaged and the way that they become pathologic. So 125 million lipid tests per year in the United States. We still recognize that 75% of patients coming to hospital for heart attacks have normal cholesterol. You'd expect them to be high. You know, prior dietary guidelines have recommended that we only eat 300 milligrams of cholesterol per day and less because we know it's bad. However, the 2015 Dietary Guidelines Advisory Committee has said there's no appreciable relationship between cholesterol consumption and the cholesterol level in your blood, meaning eating the cholesterol is not the problem. Cholesterol is not a nutrient of concern for overconsumption. So that's a US dietary guideline, and that has actually lagged most countries in Europe by about a decade. The emphasis on dietary cholesterol has shifted away. We don't think consuming cholesterol is nearly as dangerous as we've encouraged people to believe in past decades. So then what becomes the meaning of cholesterol? This is a friend of mine who kind of sensitized me to the topic. Dr. Blattel, he's practicing in Portland, Oregon, and he will say it's been more than 8 years since any of my patients, he has a very large patient load, have had a heart attack, because he's very aggressive in his approach to risk factor modification. And we have to make two distinctions here. One is your LDL cholesterol. So if you go to your doctor and you have a blood test and they measure your cholesterol, what they're going to tell you is your total LDL in your blood. What we have to realize and be aware of is the number of LDL particles that are contributing to that total cholesterol. So we have to be aware of particles in your cholesterol number, not just the cholesterol number. So how does that work? Here is a perfect balance in LDL cholesterol. You can have large LDL particles and fewer of them that weigh as much as many small LDL particles. What you want is a fewer number of large particles and a very small number or no number of small particles. So big is safe, these small are very pathologic. Both of these give you the same total cholesterol or total LDL cholesterol number. How are you going to know the difference, and how will you know that your cholesterol particles are large and bouncy like beach balls, and not small like shotgun pellets that'll go ripping through your arteries, causing damage. Again, it's the big cholesterol particles that just bounce through your arteries like beach balls, and those small ones that are like buckshot and will damage your artery wall and initiate the process of atherosclerosis. So the journal Lipidology says, always remember that atherosclerosis, which is the blockage of arteries, follows the number of LDL particles, not the cholesterol that these particles carry, which is your total cholesterol. So we want to be aware of particle size, even if we don't have opportunity to measure particle size frequently. And you can see here when those particles are measured for their size, here is probability of event-free survival, meaning the lower curves are the people who are having coronary events. And it's always that high LDL particle number, whether or not your total cholesterol is low or high, that are having the largest number of coronary events. When the particle number is low, regardless of whether your total LDL cholesterol is high or low, your event-free survival is much higher. So it's really the particles that we need to focus on, and that I think where lipid management has been failing in the past. So what we can do is nuclear magnetic resonance of your cholesterol blood sample to measure cholesterol particles. And Dr. Blattel says, I pay attention to your LDL particle number, your HDL particle number, and your triglyceride numbers. By far the most important is the LDL particle number. He says you live and die by that number. I try to get my patients less than 1,000, which is the 20th percentile. That's better than 80% of the population. And if you have significant cardiovascular risk, he'll say, I want you less than 750, which is better than 95% of the population. He says you can't be too low on your LDL particle number, regardless of your total LDL. And really 4 classes of medications can really impact the particle number, and these are the same cholesterol medications that your doctor's probably prescribing to you. The statins, the Zedias, the niacin, the binding resins. He says this is kind of the order that I bind these things or add these things, but to the end point of reaching a target particle number, not a target LDL cholesterol level. And he'll go on to say that a normal triglyceride level is in fact less than 100, not 150, so we should be using tighter targets. And we have medications to lower triglycerides, and we also know that fish oil is particularly good at lowering triglycerides. So he says virtually all of my patients are on at least 1,000 milligrams of fish oil, but not just any fish oil. It has to have the beneficial molecules, EPA and DHA, that are in fish oil. So you want to look at the label and make sure that those numbers are high, or the highest number that you can find out of the options that are available to you. The rest of it is just fish fat, and not necessarily helpful. These are the molecules that you want and that can bring down your cholesterol number. Flaxseed is very good. Not as potent as fish oil, but very good as a natural source of omega-3. Won't give you the high concentration of EPA, DHA that fish oil does. But I would encourage people to use flax oil. Unfortunately, most of the data is for fish oil. So that's the one we feel confident talking about it because it's what you feel you understand. Other things just aren't as well studied, but may prove to be just as good or perhaps even better. So what you want is concordance, where your LDL cholesterol number really predicts your particle number. Once you know those two are moving together, all you have to do is measure serum cholesterol, and you know basically what the particles are doing. When you have concordance, meaning they move together, it becomes an adequate surrogate. And you want sort of the particle number to be about 10-fold higher than the total cholesterol number, and you know that things are starting to behave predictably. This can be particularly important in patients with additional risk factors like diabetes, or a high risk for vascular disease. So patients with type 2 diabetes and LDL cholesterol less than 70, so very aggressive total cholesterol lowering, have an 84% chance of being discordant with a particle number above 700, and a 41% chance that LDL particle is significantly higher risk than what's indicated by the total LDL cholesterol. So it's interesting that our lipid panels aren't giving us the complete picture. Kind of leaves us with two options. either seek NMR analysis of our LDL and find out our particle numbers, or just start doing lifestyle dietary changes which should shift that particle distribution in the appropriate direction, and do that to the best that you're able, and hope that you're getting maximum benefit. And at this moment, that's the category that I'm in. I haven't undergone NMR analysis of my cholesterol, although in preparing these talks, it's become something that I'm quite motivated to do. But for now, it's been, hey, let's get the lifestyle as optimal as possible, with the goal of shifting those cholesterol numbers in the most beneficial direction. So finally here, let's focus on inflammation. Inflammation, this should be the word in your brain and on the tip of your tongue. We'll call this the grand unified theory of chronic diseases, including cardiovascular disease, and the grand unified theory of longevity. We have to eliminate inflammation if we want to prevent disease and we want to live a long time. What is inflammation and why should we care? Time article that it's a secret killer. Heart attacks, cancer, Alzheimer's disease, other diseases. Inflammation. So we're becoming sensitized. And let's be smart about this. Acute inflammation is in fact a good thing. This is how your body deals with insults. So here's an example of an ingrown toenail, and you can see that there's redness and swelling surrounding the site of the ingrowth, and we see acute inflammation. Has 5 characteristics. There's pain. So chemicals are released here that causes pain. That's to warn you that there's something important going on. It becomes red as the local blood vessels become engorged with blood. And you become immobile, so there's some loss of function of your toe. The whole thing swells and it becomes warm because of the increased blood flow. So this is acute inflammation. Your body is dealing with an acute process that's trying to neutralize it. This is good. This is what you need to to survive. So acute inflammation is important. Here is a pinprick into your skin. It delivers bacteria. Blood vessels recruit, migrate out of the blood vessels, surround those bacteria, and the macrophages, your immune cells, start to gobble up those bacteria. Inside your macrophages take place a very toxic chemical reaction, where if this just happened willy-nilly throughout your body, you would be in trouble. Oxygen is converted to hydrogen peroxide, and then to hypochlorite, which are highly reactive species, toxic chemicals that literally kill the bacteria, by frying them and damaging them. You don't want that stuff, even though your own cells are producing it, leaking and around throughout your body, or you don't want these processes taking place throughout your body, so your body's always trying to mop up very toxic chemical reactions that are happening, even though you may not be aware of them. So chronic inflammation, where it's going on all the time, kind of smoldering in the background, is what's deadly. And we can say that this is causing cancer, neurologic diseases, metabolic diseases, bone diseases, skin diseases, cardiovascular illness, chronic fatigue, and the chronic inflammatory conditions. A whole array of diseases have their origins really in uncontrolled, significant systemic inflammation. So chronic inflammation is an overactive immune response, because your immunity is constantly being insulted by challengers. So it results from conditions like allergies, asthma, rheumatoid, autoimmune diseases. Those things, if you have them, can be difficult to control. Realize it's a source of inflammation. It also results from your ingestions, what you're purposely eating. Animal protein tends to be inflammatory in general. Moving towards a vegetarian diet, despite the excellent sources of protein that can be available in meat, is an anti-inflammatory action. Sugar, deadly. Trans fats, food additives and preservatives, which are in all kinds of processed foods, and pesticides, which are covering our fruits and vegetables, are all sources of chronic inflammation. Exposure to smoking, heavy metals, pollution. I lived in New York City for 3 years. It's discouraging and dismaying to fly into that city and realize how long it is before you can't see it because of the level of pollution that's there. Smoking, at least we have smoking laws, but those didn't even kick in Montreal till about 2006, and we were always exposed to people smoking in public. It's deadly for your chronic inflammatory insult. So hidden inflammation running amok is a root cause of all kinds of chronic illnesses: heart disease, obesity, diabetes, dementia, depression, cancer, autism. You may feel healthy, you may look healthy, but if there's inflammation that's raging inside, you're in trouble. So we need to be aware and start to neutralize these things. Is your body burning up from hidden inflammation? Medical literature from all disciplines contains multiple references citing inflammation as a root cause of the diseases of the organ or the system that those journals are involved with. A study of generally healthy elderly people, partly our audience here, found those with the highest levels of C-reactive protein, which is a marker for inflammation, and interleukin-6, another blood marker for inflammation, were 260% more likely to die within the next 4 years. So those markers of inflammation smoldering behind you, there's no one problem you can focus on, is in fact quite deadly. Increased deaths were due to cardiovascular diseases and other chronic diseases: hypertension, diabetes, renal insufficiency, vascular diseases, cancers, ultimately attributable to inflammation. So we say, well, what's causing inflammation so we can get rid of it? There's a number of things. Acute inflammatory episodes that were supposed to be helpful but never completely cleared. So that ongoing nail in your foot that continues to be red and swollen for months or years at a time, if that was what was happening, you'd say, hey, this process is taking place much too long. Free radical damage, and we'll talk about more how you get free radical damage, but chemical reactions, responses to pollution, exhaust fumes, things of this nature that are introducing free radicals to you. High intensity training, if you're exercising exceedingly vigorously, you may acutely in the short term be getting very fit and healthy. You look great, but that training is in fact promoting inflammation in your body, which is causing wear and tear, which is going to catch up to you and cause trouble later on. Environmental pollutants, even excess body fat, high blood sugar levels. We have to be very aware of the sugar that we consume. High temperature cooking, like grilling and frying, can introduce free radicals into our food. The food looked healthy, but you cooked it the wrong way, so now it's bad for you. And then too many omega-6 oils and foods with too few omega-3 oils. So we'll talk about the balance of those and what are sources of both, but be aware that those certain fat molecules, although they're necessary, you actually need them. Having too many of them or them in excess are going to promote inflammation, which is going to cause wear and tear in your body and ultimately be responsible for chronic diseases and likely shortening your life. The dentist, periodontal disease. Are your teeth inflamed? If so, there's bacteria constantly leaking in through your gums into your bloodstream. Your body's constantly neutralizing those bacteria with toxic chemical reactions. It has to do it, otherwise these things can go and cause problems throughout your system. But by not maintaining your teeth, you've introduced or allowed a chronic inflammatory state to persist in your body, which is very destructive. So even dental hygiene plays a very important role here. Let's start to look for some solutions to chronic inflammation. I know we're getting a little short on time here. Dr. Hyman says, thankfully, the list of things causing inflammation is relatively short. And in point of fact, it kind of is. Poor diet, so sugars, refined flours, processed food, animal protein, and inflammatory fats, trans and saturated, are things that are a problem. Lack of exercise, you just exercise to pump out the inflammatory molecules in your system. Stress, you don't want unhealthy stress. Being angry, feeling overextended. You do want healthy stress, feeling motivated or inspired or engaged. You're active, you're into things, but it's a healthy way. That's good. So you don't have to be a couch potato to eliminate stress. But we all have a sense of what angry stress is. Hidden or chronic infections smoldering away in the background, allergens in your food and your mold and environment, toxins that we're exposed to inadvertently and have to be very aware of, mercury and pesticides, all sources of chronic inflammation. Here's 11 ways you're inadvertently causing inflammation. One is you're not drinking enough water. Your metabolism slows and nutrition delivery becomes inadequate, among other things. Recommendation here is to drink a minimum of half your body weight in ounces of water daily. It's a lot of water. It's a good amount of water. So do the math and get a sense of how much you should drink. You can certainly improve, I think, by drinking several large glasses per day and doing it deliberately. You know you're moving yourself in the right direction immediately. You're eating the wrong types of grains. You want whole grains and not, you know, a variety of processed grains that are stripped of fiber, stripped of nutrients. Refined grains are labeled as wheat or wheat flour. It needs to be called whole wheat. Otherwise, you're going to have an inflammatory response identical to that of sugar. You want whole oats, brown rice, quinoa. You're drinking dietary soda. Artificial laboratory sweeteners have the same insulin response as insulin itself. Can trigger weight gain, diabetes, other inflammatory conditions. You want sparkling water. If you need an artificial sweetener, here's your word, stevia. If it's sweetened with stevia, that is a natural product and in fact doesn't have the toxicities of some of the other artificial sweeteners. Second, fourth, you're eating processed foods. These are inflammatory. Processed foods, fast foods, junk foods are foods that were created for overconsumption, and they're problematic. You're regularly eating sugar. Sugar is the #1 inflammatory food. We're consuming bushels more white sugar per individual than our ancestors were 100 years ago because of its availability. It's very toxic. Its close cousin is high fructose corn syrup. So be cautious of your labels when you're buying any processed food and watch for that. Try to not have any. Okay, serious inflammatory consequences. You're missing cultured foods. We talked about your bacterial flora and maintaining a very healthy bacterial flora and what that can do for the harmonious function of your body and also for minimizing inflammation. So you want to be eating high quality yogurt, like a Greek yogurt, and even sauerkraut from time to time to promote the healthy gut bacteria that you want to be predominant inside your system. It's a little bit of a controversial topic. I actually personally use a probiotic. So the question is, what about probiotics? So that's kind of taking supplement forms of capsules containing the right sorts of bacteria into your system that hopefully are being released deep in your gut. It's something I believe in. I'm not sure of the latest research actually, but I do think that's really worthy of investigating and considering, and I'm doing it myself. Green leafy vegetables, you should be eating spinach, kale, broccoli, chard, collards. Really go for the green leafy vegetables. Anti-inflammatory nutrients to reverse inflammation. You're getting too few omega-3s and probably too many omega-6s. And we'll talk about exactly what those are, but omega-3s can really reverse and combat inflammation. Omega-3s are abundant in walnuts. That's the nut source with the greatest concentration of omega-3s, so your diet should include walnuts deliberately. Make that the nut you sprinkle on your cereal every morning or put in your salad. Flaxseed, and then the animal sources, wild salmon, sardines, fish oil supplements can really have that strong omega-3 content. Or you're using the wrong cooking oil. Vegetable oil, canola oil, soy oil, corn oil, high in omega-6s, low in omega-3s, has the wrong balance. You can pick olive, coconut, macadamia, or red palm fruit. I almost exclusively use olive oil at this stage. You're not exercising, so exercising, we said, really does minimize inflammation, or you carry excess weight. Fat cells that are engorged with lipid particles are promoting weight gain and inflammation. So just losing weight, shedding that extra fat is actually an anti-inflammatory process, and recognize that it's, more than cosmetic, or recognize why it's heart healthy. You're targeting inflammation, not just plaque and fat around your arteries. Your heart's preferred energy substrate is fat. Believe me, it'll get enough if you shed what you're collecting around your midsection. Whole foods, inherently anti-inflammatory. High fiber, plant-based, organic sources. Choose unprocessed, unrefined, whole, fresh, real foods, high in powerful anti-inflammatory phytonutrients or plant chemicals. And healthy fats. Give yourself an oil change. Eat healthy monounsaturated fats in olive oil, nuts, and avocados. And we'll talk more about that. And high omega-3 plant sources. We talked about walnuts and flax and small fish. Why small cold water fish? Because the omega-3 is actually in the algae on the bottom of the ocean that the small fish eat. So they get it right from the source, and they have the lowest concentrations of mercury. The bigger fish eat the small fish, the bigger fish eat the bigger fish, and by the time you get big fish, you do have the omega-3s, but you've also got the mercury content. So if it's going to be fish, you want the small fish who are actually eating the algae. If you want to be like the fish and eat the algae, you can do that. It's expensive and it's in health food stores, but it's available to you, and that's a good supplement. But just understand the process and why you're making those choices. So relaxing, we talked about that. Avoiding allergens, probiotics to improve the balance of healthy gut bacteria. You want to promote that healthy flora. You know, if you don't want to buy something or supplement, you can eat sauerkraut and yogurt, you know, have a couple servings a week and move yourself in that direction. And we'll spend a day dedicated to nutritional supplements. It's a controversial area, but Dr. Hyman recommends, and I use and probably recommend, daily multivitamin, multiminerals, fish oil, vitamin D, antioxidant supplements, all for the purposes of reducing inflammation. Foods that cause inflammation, sugars, refined grains, a lot of cooking oil, trans fats, milk, feedlot raised meat, red meat in general, processed meat, alcohol, food additives. We have to just eliminate these things from our diet. If it's going to be a milk, make it a skim milk. You know, minimize red meat. If you have to eat meat and red meat, you know, make it something that's been raised properly and that free range and things of this nature. And just be exceedingly careful because all these little things that we're doing are adding up to our overall health. And then we have foods that fight inflammation. Use ginger and turmeric as your spices. Use walnuts as your nut. Use avocados as your sandwich spread. Eat broccoli as your snack. Dip it in olive oil if it's not giving you satiety. And you'll all have anti-inflammatory actions. We have to deliberately move towards these things. And again, appreciate the soft drinks. The advertising is aggressive. We're all swayed. We can all sing the commercials. Cravings, cavities, obesity, diabetes, allergies, all coming from these products. And there's just no excuse to be taking these things in at all. A few more easy things you can do to fight inflammation and boost your metabolism, because it's all about the little tips and the little things that we can actually do. Have your thyroid level checked. Your thyroid needs to be normal. Stay well hydrated. An 8-ounce glass of water as soon as you wake up. 2 more drinks before you have breakfast. 2 more before lunch and dinner. It's going to boost your metabolism, and that metabolism boost alone can shed 5 pounds for you in a year. Don't forget protein. Remember, even celery with peanut butter has protein in it, but that can really boost your metabolism and help in an anti-inflammatory action. Have breakfast soon after you wake up, within 30 minutes. Reminds your metabolism to kick in gear. People who eat breakfast lose weight and keep it off compared to those who don't. So make it part of your routine. Eat regularly, 3 meals, not huge. You can snack between meals. Keeps the metabolism humming and avoids hunger cravings, so you're not reaching for junk food, which you're especially tempted to reach for when you get those strong hungry signals. Practice slow eating. If you eat slowly, your metabolism speeds up. If you eat fast, your metabolism slows down, compensating, thinking that it's going to get this huge deluge of food that it won't be ready for. And use spices. We talked about ginger, turmeric, really anti-inflammatory, capsaicin, black pepper. You know, incorporate these into your food because of their really strong anti-inflammatory action. And don't eat late at night. Late at night, you're trying to have natural fat burn, which is your body's preferred substrate when it's at rest. And if you eat that and give yourself even a carbohydrate or protein challenge, you're going to interrupt that and introduce inflammation at a time when you don't need to be introducing inflammation. Keep moving. Don't sit for long periods. Get up every 30 minutes. Do squats or leg lifts. Walk for water. Swing your arms. Even fidget. And you're moving. The buzzword is constant low-grade activity. Take control of the stress in your life. Stress causes cortisol surges, which slows metabolisms, increase your fat and food cravings. And when those hormone imbalances kick in, you're going to have a terrible time resisting those cravings. So we have to be taking action to keep the hormones in check so those cravings are mitigated. You can consider high-intensity interval training, which is something that I like to try to do. So you kind of exercise at a low level, but then for short periods of time, you'll exercise really vigorously until you're sort of exhausted. Then you go back to the low-grade thing, and you get intense all over again. And you cycle through that a couple of times, and you'll have a lot of exercise in a short amount of time. So that can be helpful. Vitamin D, let's be so conscious about vitamin D, especially those of us who live in northern climates and don't always get the exposure that we need. Vitamin D is linked to all sorts of important things. D3 is the form of the molecule that your body actually uses, so that's what you supplement on. Decreased muscle weakness, fall risk, improved insulin and diabetes. You can get D3 measured in your blood. Ask your doctor to include it in your blood work and supplement if your levels are low. Watch out for pesticides. Your body stores these in fat cells. It lowers your metabolism. They can cause weight gain. You want organic produce that's hopefully received none or hopefully at least the least of the pesticides. And wash your fruit and vegetables very carefully because it's on there. You know, no one's quite looking out for you the way that you are. And even if those vegetables have been dunked in water or there was some solution that had been dunked in 1,000 other boxes of vegetables before yours was washed, believe me, you need to be considering these residues. And green tea, if you'd like green tea, shown to be beneficial in cardiac diseases in a number of studies. It's very interesting, is a beverage consumed in populations with very high longevity. It can boost your metabolism and promote fat burn. So just be aware that that's out there. Food, inflammatory fighting vitamins and minerals. Vitamin A, the B vitamins, we'll go through these in detail. I feel like our time's a little short. C and D, we've talked about them. Recognize that they're important and they're supporting metabolic processes that are reducing your inflammation. One we'll talk about in great detail is coenzyme Q10. I'm very excited about coenzyme Q10, recommending it to pretty much all of my patients, and it's something that I'm taking regularly myself. Glutathione is the strongest anti-inflammatory molecule that your body produces. It's found naturally in a host of foods, again, plant-based whole food sources: avocado, asparagus, spinach, garlic, tomatoes, grapefruit, apples. You know, you want to be eating these things on purpose because they include the molecules that your body needs on purpose. Magnesium, we'll spend a lot of time on magnesium. Reduces inflammation. About 70% of Americans are deficient. We don't have it in our diet, and deficiency is very occult because your blood will maintain blood levels while the rest of your tissue stores are profoundly depleted because you need it in your blood. So you do a blood measure, your magnesium looks okay, and everyone says, okay, you don't have magnesium depletion. Basically, expect that you do. Really just expect that you have it and that you need to be supplementing or eating appropriately with foods that contain large amounts of magnesium, and be aware that deficiency is even worse in men and women who are overweight. So supplementing, adjusting your diet is even that much more important. And again, those are topics that we're going to develop a little bit more in the days to come. Recognize that, in summary, let's recognize that coronary disease is a cult. It is progressive. Assume it's taking place in you, whereas heart attacks can be sudden and they can occur unexpectedly. Coronary disease, heart attacks, all predispose you to the chance of you having a sudden cardiac death event. So recognize the symptoms, take action appropriately, and learn basic resuscitation skills should you be around somebody who does suffer one of those catastrophic events. Assume you have some coronary disease, really focus on risk factor control, act on suspicious symptoms. If you concentrate on your cardiac risk factors, you're going to benefit your health in so many other ways. So it really becomes a nice organizing tool to give you something to focus on. Cardiac risk, reducing inflammation, those are the buzzwords that we should have in our minds and be able to say, this is what my objective is, this is why I'm doing this is what I'm pursuing with my lifestyle changes and my activities. We talked yesterday about the mind-body connection, harnessing your mind-body connection, lifestyle reform to slow, halt, and even reverse coronary disease, eliminate sources of inflammation, and remember that life is full of second chances.